Polycythemia vera is a myeloproliferative neoplasm. It's a disease that's both chronic and progressive and can be associated with thrombosis, hemorrhage, and progression to myelofibrosis and acute leukemia. Right now, the first-line therapy for PV is hydroxyurea, although some physicians and patients will choose interferon alpha, particularly if they're younger, and the idea is to potentially modify the disease course. Busulfan, if you are older in age, is sometimes used. But the only FDA-approved drug for second line if you fail hydroxyurea is ruxolitinib, which is a JAK2 inhibitor previously approved for myelofibrosis. This is a drug that is oral. It's given twice a day and has had profound responses in myelofibrosis in terms of improving symptoms and spleen and what appears to be a survival benefit in patients who take this compared to patients who don't take this drug. In polycythemia vera was sort of the natural extension of this drug. It was explored in a randomized phase 3 study called the RESPONSE study, which was the pivotal study that led to the approval. And it was in patients who were intolerant or resistant to hydroxyurea, and there are formal definitions by the ELN for that subgroup of patients. And if these patients had continued phlebotomy requirement and palpable spleen, they were randomized 1-to-1 to Rux, 10 milligrams twice a day, or best available therapy, in which many patients actually continued on hydroxyurea. The primary endpoint at 32 weeks was a composite of spleen reduction and symptom score reduction, which has also been used in various forms in myelofibrosis. And sort of not surprisingly, the Rux arm was superior, both in multiple ways. It was superior in reducing spleen, reducing symptom burden, but also negating the phlebotomy need for many patients that received the drug, or at least reducing it. Now, whether that affords the patient a true benefit is up for debate, but it met its primary endpoints, it met its secondary endpoints. What it also probably showed is that the drug is effective in improving how patients feel with the disease. It's unclear to me, because the study wasn't designed that way, whether it actually reduces thrombotic risk, which is really the reason why we use cytoreductive therapy in PV. Having said that, at 80 weeks there was a non-statistically significant reduction in thrombosis in the Rux-treated arm compared to the best available therapy. Again, not powered or designed for that endpoint, but to keep in mind when you're treating patients that this is not necessarily a proven thrombotic risk-reducing agent, but it's definitely a drug that if you have patients with polycythemia vera, particularly symptomatic patients in my mind, those with refractory aquagenic pruritus or spleen-related complaints, fatigue, bone pains, headaches, things of this nature, ruxolitinib is a reasonable option if hydroxyurea particularly is not working. The one thing I would point out to practitioners is that there's probably an increased risk to some degree, maybe 6 to 8% of patients who get the drug for viral infections, and zoster in particular. So to be aware of that, and one may, although there's no consensus on it, one may want to prophylax, particularly an older patient for zoster with antiviral therapy. Something to consider. There was a slight increase in non-melanoma skin cancers. For me, that was a little bit difficult to tease out because all these patients had hydroxyurea, in some cases a lot of hydroxyurea previously. Not entirely sure how much that was related to the ruxolitinib. But it was a positive study, and the RESPONSE 2 was a follow-up study in basically the same patient population minus the palpable spleen, and that also was a positive study that showed that patients could benefit from the drug. So it's now an available agent since, I think, 2014 for those patients who are second line now for PV.